Welcome to Demystifying Mortality Data for Critical COVID-19 Insights. My name is Claire Crivero. I am the focal point at Datavant for our support of the COVID-19 research database. I also work on public sector and academic partnerships, and I'm thrilled to host and be moderating this panel today. I want to start with just an overview of our objectives. We're going to start with some quick introductions of our panelists. We have two research groups joining us today. I'm going to do a quick introduction of mortality data, orient us about what we're talking about today, and then I'm going to hand it over to our panelists to talk about their specific research use cases, particularly in the wake of COVID-19, how they've been using mortality data. And our panelists today are going to talk about not only the outputs, the wins from their projects, but also some practical considerations for using mortality data in your work, in our work. And finally, we want to hand it over to you, the audience. We want to have saved some time for a question and answer. Please use that Q&A function in Zoom. We'll be monitoring the Q&A throughout the presentations, and we'll try to get to as many questions as we possibly can. And if we don't get to all of the questions, we'll follow up after the webinar and try to reach out to you directly. So before we launch into the panelists' research projects, I want to just plug the research database for a moment. The COVID-19 research database is the product of a cross-sector partnership that came together about a year ago. The goal was to accelerate the amount of real-world data available to researchers, policymakers, any non-commercial research team to better understand and mitigate the effects of the pandemic. There are too many partners to name, but a few of our key data partners include Change, Veradigm, Symphony. We have many others. We have technical partners such as Mirador Metadata, an amazing governance, data governance partnership with the Healthcare Cost Institute, HCCI. And today, as a result of this partnership, we have 13 private data sources, 55 public data sources, and we're adding new data sources all the time. One note on those data sources, A3AI is going to talk about their use of a linked data set, linking mortality data to other real-world data sources. We have a second linked data set that's going to be released as part of the database later this week. So if you're interested in real world data for your work, and in particular, these new linked data sets will be made available later this week, please do visit the website, register, and we send out periodic emails with updates about the data available, the research from research teams, such as the ones that we're featuring today. So yes, do stay in touch, do register at the website. And now I'd love to introduce our panelists, or I'll have them introduce themselves. So let's start with our colleagues from A3AI.
Oh, hi, my name is Cheng Rong Ji, and my friends call me Ji. I'm the founder of A3AI, and we'll talk a little more about A3AI. I am a machine learning and data science practitioner. I'm also affiliated with Blue Cross Blue Shield.
My name is James Scott. I am also a data scientist working under G at A3.ai, and I also am a data scientist at CareFirst Blue Cross Blue Shield.
Hi, my name is Yupo Wong. I'm a lecturer in discipline in the Actuarial Science Program at Columbia University. My interests resides in mortality analysis, financial modeling, and machine learning practices.
Hi, I'm Lina Shi. I'm the program director of this Actuarial Science Program at Columbia University. In addition, I teach predictive modeling in finance and insurance, this area. So we love to use some of those mortality data and database.
I'm Abraham Weishaus. I'm a lecturer in discipline in actuarial science at Columbia. I teach the core courses there, and the core courses include a course in life contingencies, which involves, among other things, estimating mortality rates.
Wonderful, and thank you all for joining us today. We're so grateful that you've all made the time to share your work. And then before I hand it over the microphone, I want to just give a quick introduction to mortality data, just sort of to set the table for our panelists today. Mortality data, and I think this is no secret to everyone here, it's a critical endpoint for any number of areas of analysis. At high level, mortality data is critical to measuring the potential impact of life-saving pharmaceuticals, interventions, policies. It's also important for informing insurance plans, retirement plans. It fundamentally impacts how we organize and plan our societies. And the visualization on this page, I think is a really important one. It's the result of a collaboration between The Economist and A3AI. I know G is going to touch on this a little bit, this collaboration a little later. And The Economist published this article just last week. And the data visualization here depicts risk curves for hospitalization and death for COVID-19 patients. And I want to recognize for a moment before we jump into more detail in all of our research projects that, as an epidemiologist or, an actuarial scientist, a modeler, it's easy to talk about this in the abstract. And although this kind of visualization is a triumph in terms of data aggregation, visualization, taking data and making it into information, actual information, it does represent the gravity of mortality this past year in the wake of COVID-19. And I think we have all personally, and I think professionally, have a vested interest in better understanding this data so we can responsibly incorporate high quality mortality data into our analyses, models, predictions. And we should make sure that that data is turned into actionable information for us in our communities. And I'm thrilled today that I have the privilege of introducing two research groups who are doing exactly that, trying to incorporate the high quality mortality data into their work to better inform the public and also their particular disciplines. So on that note, where is mortality data? And this is tricky because mortality data is not part of the usual healthcare data sets that we wrestle with. Healthcare data is often gathered as part of interactions between patients and their sites of care. So physician notes, claims, prescriptions, and unless a patient dies in a hospital bed, that mortality data is often missing from those data sets because deceased patients do not interact with the health system, do not generate data the way living patients do. So today we're talking about this death index, the mortality data available in the Datavant ecosystem. And this data includes US mortality data that is sourced from the US Social Security Administration dataset, as well as online obituaries and newspapers. And across all the data systems, the data in this ecosystem, the mortality data covers mortality from 1899 forward and covers more than 85% of the US population. And I'm actually going to stop there because the Columbia team did in their work a comprehensive analysis of this particular data set. And they're going to go into the pros and cons, the limitations, and the promise of this particular data set better than I ever could. And before I hand over the microphone, we're going to do a quick poll to better understand who we're talking to today, understand the audience. So you'll see a poll pop up on your screen, and we'd love for you to share with us how you are using mortality data in your work. Is it in actuarial science, health economics, population health, patient safety, public policy, other, or you can indicate that you're not currently using mortality data in your work. And I'll give everyone about 7 more seconds to answer. All right, we can start looking at the results. Oh, it looks like a lot of people aren't using it yet. So I hope this is informative of what the possibilities are. We have some population health researchers, it looks like, and we have actuarial scientists in the audience as well. This is very helpful for us. And I hope for those of you not currently using mortality data, we can help orient you to this particular resource, the pros, the cons, the caveats, and perhaps some potential outputs of incorporating this into your work. So thank you. And with that, I would like to turn it over to the Columbia team.
Yeah, good morning, everyone. Good afternoon, everyone. The mortality assumption is the most important assumption for life insurance company as well as for this retirement plans in the United States whole wide world. This mortality projection scale, MP, has been annually developed by Retirement Plan Experience Committee, RPEC, of Society of Actuaries, SOA, since 2014. The MP 2020 is the latest version of this series. The RPEC believes that the annual developed this MP produces very reasonable mortality improvement projections for measuring obligations for most retirement plans in the United States. They also show that any inclusion of additional most recent years data impact the obligation value. So, but therefore, it's very important that we can incorporate those new, most recent years data into those mortality analysis. One challenge though in mortality analysis is the latency in quantity population mortality data. Many established database such as SSA, Human Mortality Database, HMD, can have a lag of 2 years. So for instance, MP 2019 was developed based on SSA and HMD on their mortality database for the data up to 2017. So last summer, we, three of us, Dr. Yubo Wen and Dr. Weisos and myself, Dale Hall, Managing Director of Research Department at SOA, along with 4 our students, we were looking into the data source that actually could allow us to incorporate those most recent additional mortality information into the mortality improvement, this especially into this MP 2019 analysis. So we are aware of this death index at Datavant, and will able to incorporate those death the death index into our this mortality analysis model. So today we are going to just cover 3 items. How do we incorporate this the data count into our model? And we want to highlight the impact of incremental updates of the model with those new data we incorporate in. And finally, we are going to have a conclude remark to cover some of caveats and further research will be possible. And now I'm going to hand it to my colleagues, Yubo Wen.
Thanks, Lena. So you can see we're very excited when we learn that Datavant's death index is available and generously provided by Datavant for research purposes. So let me start with highlights on the value adds and the challenges or caveats associated with DDI, the Datavant's death index. Next slide, please. Yeah, in terms of important value adds, one thing is its low latency, which is a key challenge in mortality analysis. The DDI captures 90% of deaths that will eventually be included in their database in a calendar month by the 14th, by the middle of the following month. This low latency can be very valuable for information mining. The second value add is its frequent updates. The DDI provides weekly updates to include new records and amend past records. And these frequent updates contribute to the latency and accuracy of the database, which we appreciate. And third, also a very important benefit is that the DDI has high resolution coverage. The DDI provides individual death records, which people can aggregate these death records by age and gender, for example, for analysis. The resolution on age at death, for example, can be as high as plus to minus 1 month. Next slide, please. So sorry, go back 1 slide. Yeah, so these are the key value adds. There are several other benefits of using this database. But let me move on to some of the challenges that we faced when we are incorporating this data set that may be of interest to other researchers as well. First of all, as Claire mentioned, the DDI is mainly a US mortality database. In fact, 99.6% of the records in DDI are of US deaths. The rest is from Canada. However, there isn't a filter or flag that we can use easily to exclude Canadian records. So that's something that to keep in mind. Second challenge would be the way that the database label birth and the death dates. It defaults the date of death and birth to the first day of the month. And if one is interested in estimating age at death, for example, the age at death would be overestimated if the birth date occurs after the death date in their respective calendar months. So something to take note. So the resolution on the age at death will be about plus to minus 1 month. Thirdly, a third challenge is gender. Each deceased person in the DDI has two records, a male version and a female version. The DDI estimates gender probabilities for each record based on that person's first name. The ambiguities in gender determination present challenges for analysis. What we did is to exclude records with gender probabilities less than 50% and mitigate that impact by a capture rate function that we model, which we will talk about in a bit. Lastly, another caveat is the capture rates of the database. The DDI seems to under-capture death counts across calendar years as well as across age, and we'll provide some detail on the next slide. Next slide, please. So as you see, this table compares the DDI death-based annual death counts to those from the human mortality database. If you look at the right-hand two columns, you'll see that the DDI captures majority of the deaths, especially in recent years. But in terms of the whole population death counts, it still misses by a meaningful portion in an uneven manner across ages. For years between 2006 and 2009, DDI seems to have missed the total death counts by a wide margin. So one way to mitigate that is to use recent data from DDI that's not available in other databases, and perhaps use other databases to supplement historical experience and historical counts. Next slide, please. So since the DDI under captures death counts, one way to estimate full death counts for a year, for example, is by way of a capture rate function. On this chart, there are two lines. The more volatile blue line is the average ratio of DDI and HMD death counts for each age, as the human mortality database is used as a benchmark. The purple line is the fitted capture rate function using a polynomial logistic generalized linear model. We use this capture rate function to help us estimate the full year's death counts. Next slide, please. So now we're ready to focus on population mortality trends with the benefit of recent data from DDI. Here we use a two-factor deterministic mortality improvement model to investigate the impact of recent mortality experience. A mortality improvement rate, which we'll show in the following slides, for a given year represents the percentage decrease in mortality rate that year compared with the previous year. Next slide, please. So these are heat maps of mortality improvement rates. Warmer colors here are associated with decreases in mortality risks relative to the previous year. The heat map on the left is fitted with data up to 2017. And the chart on the right is fitted with data up to 2020. So we add 3 additional years of data from DDI and other sources. If you look at the circles at the bottom, those are for young male in their 30s. We see that the previous expectations of mortality disimprovement has been borne out by recent experience, and this disimprovement is expected to continue in the near future. Interestingly, if you look at the circles on the top of these charts, these are for senior male in their 80s, contrary to previous expectation, which is on the left chart. The Some mortality disimprovement had occurred in the past few years and is now expected to continue for the near term. These heat maps show how incorporating the DDI data can help us incrementally update past experiences and future expectations. The next slide, please. We can also, in addition to the heat map that we just looked at, we can also look at each cohort separately. These are historical and expected mortality improvement rates for the baby boomer cohort born in 1946. The relative gaps between these lines indicate the incremental impact of including an extra years of data in the model. These gaps suggest that 2019 and 2020 are the main drivers of reduced mortality improvement expectations for the near future for this cohort. Next slide, please. So these are for Generation Zs born in 1995, the younger generations. For younger generations, including Gen X, Millennials, and Generation Z here, have typically suffered stronger mortality disimprovement over the past decade. Interestingly, if you compare the two charts, for Generation Z, the impact of new data, new information on the expected mortality trends is much weaker for female than that for male. With that, let me pass the presentation to Dr. Whitehouse for additional perspectives and the concluding remarks.
Thank you, Yubo. Next slide. The main use of mortality rates in actuarial work is to measure the longevity risk on pensions and annuities. Having more recent data helps get a better estimate for these future mortality improvements, and DDI is an excellent source of this newer data. DDI is a set of death records. To calculate mortality rates, you also need a base, you need a population, and that must come from another source. Our study of mortality was based on a two-factor mortality projection table, namely projection based on age and cohort. It's a deterministic projection. It gives you a fixed mortality rate in each future year. For future research, we may also want to try applying DDI to a stochastic model. A stochastic model is more interesting in that it allows you to measure the risk, the distribution of future mortality. Using more recent data gives us two advantages in building the stochastic model. First of all, you can get a better estimate of the parameters of the model. And second of all, you get a better starting point. So as we've discussed, the DDI is a valuable resource for getting more up-to-date mortality rates and is useful not only in the actuarial field, but in other fields that use mortality data.
Thank you. This is fantastic. I really appreciate you all sharing your work with us. And I think we can now, I'm going to stop sharing my screen. I'm going to let G share her screen. We can move on to our second research group. And I would just note as we move on to the next presentation, the key thing to note is that the DDI, the death index that we just heard about, that was the standalone DDI. And now we're going to hear from a research group that used a data set that incorporated the DDI, that linked the DDI. And when we do linkages, Datavant works with a statistical certifier that makes sure that the data set cannot be re-identified to patients. So we, as per that statistical certification, have to redact or change data sets to ensure that re-identification is not possible. So the data set looks a little bit different for this particular research group, but I'm sure G will go into more detail. And with that, I hand it over to our colleagues at A3AI.
Can you guys hear me?
We can hear you. We see your desktop. I think
okay, great. Okay, so we're good. All right.
All set.
Great. All right, so first a quick word on A3AI. We're a bit of an unusual research group. We are a completely not-for-profit applied AI R&D project. There are about 30 plus expert volunteers with bring to bear about 600 years of industry experience in healthcare, AI privacy, digital health, and blockchain. So we have hackers ranging from 18 years old to 70-year-old, and we work nights and weekends on these stuff we believe is impactful and fun. So this is our COVID-19 research sub-team, a good part of A3AI. Won't go into the details, but that's get into mortality data key stats. To Claire's point, we are using a special linked data set of claims, social, and mortality three-way join. These are de-identified personal data. So as of March 2021, there are about 108 million patients' claims data, up to 7 years of claims history, 4+ billion claim lines. And then there's another very interesting data set by another data donor. Is about 400 million consumers with 80 social attributes, things like BMI, social economic, education level, occupation. And at the intersection of these two data sets, there are about 40 million people. So for 40 million people, we actually have a pretty rich view of these people's medical history, longitudinal medical history, and what they are about in terms of, like these social things. So that provide a very fertile, interesting ground to do all sorts of analysis. Now, when intersecting this data set with mortality data, which to Claire's point is about 80% of what US death in the last however many years, there are about 237 million people in the death index that we have access to in this linked set. About 5.5 million people, they gave us an indicator called died in 2020. And then out of that, about 40,000 people are at the intersection of died in 2020, as well as this aforementioned medical records. So it's based on these subsets that we are building our models. How do we use it? First, led by our physician data scientist, Mahesh. So we handcrafted about 30 underlying medical conditions according to the literature. These are what we believe are relevant or contributors to COVID. We also mine the claims data to look for the COVID infection date, where these people reside, their social data, like I said, behavioral spending patterns and stuff like that, religions, political leanings, and all that sort of things. And then we also look at people who died of all causes in the mortality data and look at their underlying medical conditions, and then compare the subset of folks who passed away but who are COVID infected during 2020. And with that intersection, we assume these people are died of COVID. As you know, that's just a proxy, but that's kind of as best as it gets due to the de-identification needs. So we are playing with those numbers. Now, I'll give you an example of the data distribution. By the way, this is A3AI's website, and we have a bunch of research papers for folks interested in finding out more about our work. So this is a bar chart racer. We take from March to end of the 2020, we take the COVID infections every week, and then later map to folks who passed away according to mortality data. And so that's kind of the weekly death compared to the other top 5 leading cause of death. So as you see the bar chart, you see kind of, there's a spike, there's the wave 1, wave 2. So this is, a way. Now the 2019 CDC data supports these other top 5 cause of death, but then these are from the research database, upscale to the US population level. This is another view. This is, we take people, the cohort, and find out their hospitalization rate and COVID death rate according to age group. You can see they kind of seem to be commonsensical. Over here, the hospitalization rate kind of reduced, which confirmed by our medical people that sometimes the higher rate, even though the mortality rate steadily increase as age, the hospitalization, some older people choose to just not go to hospital. Now, this is another view. The blue bar here, out of the 30 underlying medical conditions, we picked the top 14, the more prevalent ones. So these are the all-cause death in 2020 for people who had dementia, kidney disease, stroke, and stuff like that. But with COVID, you can see the death risk increased typically 2 to 3-fold. Now, this last chart comes from the social data set. The BMI, interestingly, comes from our social data. So as you can see, the blue bars are the COVID infection rate, regardless of BMI, they're about the same, yet the mortality rate significantly increase as the BMI goes up. So I'm going back to the presentation. So I'm going to hand over to James to talk a little bit about the AI machine learning models we built. James?
Yeah, can everyone hear me?
Yep.
All right, thank you. Thanks, G. So as G was saying, we use different variations of this linked data set to develop machine learning models pertaining to severe outcomes, so hospitalization, ICU, and death. Hospitalization, ICU, we developed models using claims data. However, with death, we use a variation of medical data, claims data, and mortality data, along with social data, to develop our data set that encompassed 30 to 35 unique features and predictors that we deemed important to predicting the overall outcome of death. So to get into a little bit more about that, I developed some of the predictive models pertaining to the predicting death probability. So some of those models included deep neural networks, random forest, and XGBoost models. Each had different variations of how well they performed on the data set. Deep neural networks had very high performance, as you can see in the bottom right graph, being able to produce precision recalls, high precision recall. However, deep neural networks there's a couple drawbacks with that. It was very robust, requiring a lot of computer resources, and that type of model was not, I would say deep neural networks don't have a lot of explainability factor as random forest's XGBoost when it comes as to why it's predicting these certain probabilities or outcomes. Random forest had good explainability. As you can see by the graph in the top right, these are some of the important features that we use in our model and how random forest ranked them by their feature importance. So as we can see, age is the most important factor by far. And then we get into, I believe it is days since 2020, which is just an overall representation of the time of infection and when the patient got infected with COVID. And then we get into dementia, heart, CKD, and UMC, which is just the overall score of a person's health. And then getting into the XGBoost model. The XGBoost model was lightweight. It had better predictive power than random forest, and it also gave us the opportunity to add confidence intervals to hospitalization and death probability. How confident are we in the given answer and the given said probability? So I believe now I'm going to hand it back off to G so she can demonstrate this XGBoost model of live in action hosted on the Economist website.
All right. So this is the aforementioned XGBoost model right now live on the Economist website. It's in front of the paywall, so it's free to use. So over here, you see two bars. The gray bar is the hospitalization risk, and the red one is death risk. by age. And over here, as I move through, you can see, you know, at any given age, for example, a 45-year-old woman, the death and hospitalization risk, it's, you know, as shown. And then it also shows, you know, the relative risk compared to the general population. Now, as I start adding underlying medical condition, for example, the same people with asthma, you can see the death risk and hospitalization risk start to go up. Now, as underlying medical condition compounds, for example, if somebody with chronic liver disease and asthma, oh, something keeps going. Let's add on a form of cancer. So as you see, you know, at different, some of these, you can see some of these bumps, they are the result of, you know, the nuances of the training data, but overall you can see the trend of, you know, having underlying medical conditions, specific combination underlying medical conditions add to the mortality and hospitalization risk. So let's go back to, there are other models such as causal models, fixed effect models, and we also build clinical concept embeddings. So various techniques to either predict or do analysis of different risks. Some are, for example, some are related to, for example, geolocation or political leaning. Some of them kind of turn out to be red herring, you know, once you apply causal models, some of these simple correlations kind of get ruled out. So now the values and caveats we have on our hands, we believe probably is one of the largest, the broadest anyway, data set with the identified personal level, social, medical, mortality data all in one place. They are different death risk calculators by, say, Hopkins and CDC. They come from different angles. Some are like deeper and narrower data, but this is broader. Now, the caveat is that we use there's no cause of death in the mortality data, at least in this link set. So we can only kind of, you know, proxy it as a COVID death. Also, the linkage between different data sets is a probabilistic match, not a exact or deterministic match. And then different data set, because they come in from different data donors, they have different latencies. So for example, if we identify somebody with hospitalization and with COVID in December, but there's no mortality data on it, we cannot confidently assume that person survived COVID. We may just like, we don't know yet. And then there's also, due to the de-identification reasons, there's some data anomalies. For example, over here you see a bump of death rate at age 80 and age 89. I think this is related to people probably been some higher age into this particular age group. So we kind of have to smooth out or throw away some of these anonymous, novel data. So in terms of wish list, it would really help if there are finer granularity. For example, adding month of death to the mortality data. This will give us a better guess of somebody truly died of COVID or not, you know, maybe by looking at the infection date and the death date. And then another big wish list is linking more data, but Claire, you can speak to that. I'm going to hand over to Claire.
Yes, absolutely. And I think those last two pieces, the wish list that G flagged there, I think there's two important concepts that she highlights with that. That you'll notice that our Columbia University colleagues touched on the month of death being available in the standalone data set, but that G's team wasn't able to wrestle with that granularity of month of death. And that is due to what I mentioned before, those redactions to align with a statistical certification to minimize to near zero the risk of re-identification of patients. And that is this tension that we balance. And I'm an epidemiologist by training, so I feel such empathy for the research teams who need that granular data for big research questions and simultaneously needing to adhere to that statistical certification. The good news about that second wish list item, that EHR linking more data sets with mortality. As I mentioned at the top, that we actually are going to be releasing that new linked data set very shortly. So we hope to release it on Friday. And again, I encourage everyone to visit the COVID-19database.org, register there. We'll send out an update and that common data schema. So it will have mortality data along with EHR, claims data, the commercial data that G touched on, that will all be linked in one data. So it'll be available to the non-commercial researchers. So please do register so we can keep you updated. So now we have time for questions. I encourage, if you have a question that's come up during the presentations, please use that Q&A function. I can kick it off quickly, and maybe we can start with A3AI and then move to our Columbia colleagues. I'd love to hear, G, now that you've explored this data set, and I know, again, in my research experience, a new data set takes a lot of work. There's a lot of startup costs to understanding the data set, accessing it. Even if it's available pro bono like this database, it does take some time to better understand the promise and limitations of a given data set. Now that you've done that initial work, what are the next big questions that you hope to unpack with mortality data now that you've done this initial project? Your hypotheses, or anyone else at A3AI who's looking forward to more mortality research.
Yeah, we have a whole lot. In fact, we got more work cut out for us than we have time for. We are very excited to further explore things like long COVID, right? Because with the vaccine coming, I think the research interest is going to start more shift toward these COVID downstream effects. People recover from COVID, what happened to them over the long run? So long COVID is one, and then we are also looking at some for example, population gender-based analysis. We are talking to some colleagues at Hopkins to kick off some of these projects, as well as like drug repurposing, as well as like risk factors. Get deeper into for example, lymphoma patients, pediatric, or people with certain type of underlying medical conditions. Because we have the luxury of such a breadth of a data, we can afford to zoom in onto these subpopulations that are otherwise hard to study due to the lack of the data.
Wonderful. And our Columbia, I know you touched on stochastic models as a potential next area of research, but I'm interested in, for the actuarial, we had a few actuarial scientists on this call, so I'd love to get from the Columbia program, what are the areas of research you're hoping are pursued now that this new death and, I know you have a report coming out with the Society of Actuaries that will publicize your analysis of the data set, and what are your hopes for your area of research using this data set?
Well, let me start there. One is, as you and Dr. Weiss has mentioned, stochastic models can be adopted for comparison and then to gain distributional insights on mortality projection. Another area would be to expand the deterministic model and to some extent stochastic models to incorporate expectations based on social economic factors and outlook. With some overlap with what G has alluded to. That would be an interesting thing as well.
And we had a few questions.
I think that covers most of the possible research. I think one other area, although I don't think we'll go into this, is are there better models than MP 2014, better deterministic models? That model just assumes that in the long run, mortality improvement will be 1% a year, varying by age, but it's very simple. Is there anything better that you can do?
Well, that's fantastic. Thank you. And we had a few questions come in the Q&A. Does Datavant own the data and sort of the availability of data? So if you want to use this data, where do you begin? And I can touch on that, as well as another question about the sources of data for the DDI. So let's start with sources for DDI, and then I'll talk about accessibility. And my panelists, feel free to chime in with your thoughts and experiences as well. For the sources of DDI, DDI includes that Social Security Administration death master file data, as well as obituary data. So obituary newspaper data that is incorporated, joined with that SSA data to create a more complete death data file. So I hope that answers that just begins, but I know that the the Columbia team has done some extensive unpacking of the death index, so they might have some more color there. And then how to access this data. If you want to use the data for non-commercial research, these teams used the COVID-19 database. If you are interested in doing research using that database, within the database, the mortality data is available there. The mortality data is also available, as a standalone data set in addition to those linked data sets we touched on with A3AI. The way to get access to that as a non-commercial researcher is to register on the COVID-19 research database, and then you can see those data dictionaries. So you can see what the immense number of variables available, and you would write a short abstract that details aim to do with it. That goes to we have a data governance team. We call it the Scientific Steering Committee. We have Dr. Mark Cullen from formerly head of the Population Science Division at Stanford University. He oversees the SSC, receives those abstracts, and they have a panel of reviewers who just check the data check the abstract for scientific rigor. We want to make sure that truly we are getting non-commercial research of a certain degree. It's very lightweight compared to other processes I and others have gone through to get data. So it should take about 2 weeks to get through the SSC, and then you can get provisioned data within an Amazon workspace. So the data to access and do your analysis, you do it within an Amazon workspace, not on your own machine, is one caveat I would add there. So the death data index is a Datavant data source. That is the only Datavant data source that we actually curate in-house. But you can, if you're a non-commercial researcher, you can access it via the database, via the COVID-19 research database. If you are a commercial researcher, please do reach out to us directly. There's a number of different ways. There's a menu of options for you as well. So I wanted to focus this, and I know our audience is mostly the public sector, so focusing on those researchers, but please do reach out if you have commercial research interests. Any other questions or any other color from our panelists? Any other thoughts? All right, going once. Any other questions or concerns for our panelists? I can give people back a little bit of the day, unless there's anything our panelists want to close with. Going once, going twice. Well, I want to end by thanking so much our research teams who've shared their work with us today. Thank you, panelists. Please feel free to reach out if you had questions you didn't want to cover live. Reach out to me directly, ccorvero@datavant.com, or register for the database. All those requests go straight to my inbox as well. So feel free to reach out. We are thrilled that you chose to join us today. And again, thank you, panelists. Cheers.
Thank you.
Thank you.
Bye, everyone.
Bye.